Hello, and welcome to 23 or Less, the show where we talk about the topics that matter. Featuring your favorite video hosts Syed Ahsan, Chantelle Bishop, Monique Genard, and Samir Momand. On today's show, childhood obesity. This 25 or less session will discuss the following areas. Childhood obesity is defined as a medical condition that occurs when a child is well above the normal weight for his or her age and height. According to the World Health Organization, obesity is further defined as having a body mass index, which is the number obtained by dividing a person's height by their weight, of 30 or greater. Though a child may be taller or shorter, heavier or lighter than other children the same age, changes in height and weight generally follow a regular pattern in which height and weight change proportionally as a child develops. When children are off this healthy weight trajectory, their weight gain is disproportionate to their change in height, meaning that they accumulate excessive fat and can be classified as overweight or obese. Please note that the term overweight is also a term that refers to a person having excess weight. However, it is further classified as having a BMI in the range of 25 to 29.9. The National Health and Nutrition Examination Survey has been tracking childhood overweight and obesity rates since the 1960s. Since this time, the rates of obesity among children have been increasing at an exponential rate. From 1963 to 1970, 4.2% of 6 to 11-year-olds and 4.6% of 12 to 19-year-olds were obese. In the last survey, from 2007 to 2008, 19.6% and 18.1% of 6 to 11-year-olds and 12 to 19-year-old kids were obese. That's an increase of over 3.5 times among Canadian children. Childhood obesity affects both rich and poor countries. However, the vast majority of overweight and obese children live in developing countries, where the rate of increase has been more than 30% higher than that of developed countries. According to Statistics Canada, 31.5% of Canadian children, an estimated 1.6 million, are overweight or obese. Childhood obesity has become so prevalent that it is consistently referred to by many as an epidemic and one of the most serious public health challenges of the 21st century. According to a recent article, parents could soon begin to outlive their children because of an epidemic of obesity afflicting the younger generation. Many youngsters are now so grossly overweight they face premature death. Characterized by excessive body fat, the detrimental effects of childhood obesity are widespread. Childhood obesity has both immediate and long-term effects on health and well-being. Increasingly, obese children are being diagnosed with many health ailments previously only seen among adults. Of the immediate health effects, obese youth are more likely to have risk factors for cardiovascular disease, such as high cholesterol or high blood pressure. They are more likely to have prediabetes, a condition in which blood glucose levels indicate a high risk for development of diabetes. Children and adolescents who are obese are also at greater risk for bone and joint problems, as well as sleep apnea. In addition to physical ailments, obese children are also at greater risk for suffering from both social and psychological difficulties. This is because obese children are more likely to be victims of the stigma associated with being overweight or obese. They are more likely to be teased and bullied, have high levels of stress and anxiety, and to have poor self-esteem. Since most obese children do not outgrow their weight problems and, in fact, are likely to continue to gain even more weight as they age, the long-term effects of childhood obesity include a greater risk for heart disease, type 2 diabetes, stroke, osteoarthritis, and several types of cancer. The monetary cost of childhood obesity is also great. Childhood obesity increases healthcare costs and increases the loss of productivity in the economy, as a result of a greater level of absenteeism and weight-related illnesses among our aging and more obese workforce. In fact, an adult who is obese at age 40 can expect to die 3 to 7 years earlier than someone who was of a healthy, normal weight at the same age. The loss of years is the same as if that person had been a smoker.
I'm going to be discussing the recent evidence that surrounds childhood obesity in North America and then Canada in specific. After looking at some evidence, I will look at one particular study that focuses on a specific risk factor associated with childhood obesity. After analyzing this study, I will follow up with some further recommendations on prevention of childhood obesity in Canada as well as North America as a whole. So I'd like to begin by discussing the background information and concurring themes that have come up again and again in my research and literature reviews regarding obesity in children through Canada as well as North America as a whole. So recent evidence suggests that obesity prevalence has increased significantly in both children and adolescents during the past couple of decades. When looking at North America specifically, approximately 1 in 3 children are considered either overweight or obese. Although the overall proportion of children with obesity is hitting a plateau, the rates of severe obesity in children continue to be on the rise. Now we can look at a description of obesity that comes up when looking in literature and peer-reviewed articles. So the WHO defines children to be overweight or obese by assessing their BMI on an age and sex-specific growth chart. Overweight children are those whose BMI rank from the 85th to 97th percentile in their age and sex-specific growth chart. Similarly, obese children are those whose BMIs are considered to be in the 97th percentile or higher. Evidence suggests that there are a multitude of factors that can influence childhood obesity. These include genetics, so for example, the metabolism of a child, nutritional intake, such as the eating habits, junk food intake, etc., that a child has, the level of physical activity, so the amount of exercise that a child has, sedentary behavior, such as watching TV a lot of screen time, and finally, social and physical environmental factors, so the maternal adiposity and gestational diabetes when the mother was pregnant with the child, all have an effect on the likeliness of a child to develop childhood obesity. As I mentioned earlier, there are a multitude of risk factors that have an effect on whether or not a child will develop childhood obesity in their lifetime. One of these risk factors is nutritional intake. Nutritional intake has a very important role in the development of childhood obesity, and certain nutritional habits and behaviors are associated with an increased rate of obesity. These include high caloric intake during infancy, the introduction of solid foods before 6 months of age, eating while watching television, skipping breakfast, reduced family meal times, and lower intake of dairy milk, fruit, and vegetables. Another risk factor that is pivotal in the development of childhood obesity is physical activity. So the majority of guidelines recommend at least 60 minutes of moderate to vigorous physical activity every day for children and adolescents. Unfortunately, in Canada, approximately 93% of Canadian children, so those aged 5 to 11, and 96% of adolescents, so those aged 12 to 17, fail to meet these guidelines. Low levels of physical activity combined with sedentary behavior are associated with higher BMIs and thus childhood obesity. My discussion on the importance of physical activity in the development of childhood obesity leads right into my next topic. So I'm now going to be looking at research that assesses the impact of specific factors, so in our case, physical activity, on childhood obesity. While there have been a lot of significant studies done on many of the risk factors associated with childhood obesity, I have chosen to look at physical activity specifically because I believe that it is one of the most, if not the most, important risk factor that is associated with childhood obesity. So this research study is based on the activity levels of Canadian children. The study was conducted by Ian Jansen and it was published in the Canadian Journal of Public Health. The aim of this study was to address the importance of physical activity on managing childhood obesity, looking at the different means through which children at school age get their physical activity, so transportation such as walking or biking to school, physical education classes, and then playing sports for school. Then, the study compared the amount of physical activity of Canadian children to the Active Healthy Kids Canada report card on physical activity for children and youth. Finally, they looked at active play, such as playground games, ball games, and sports that take place on the schoolyard, and compared them to different forms of physical activity. The study found that active play, such as ball games, playground games, and sports, is a form of physical activity where school-age children expend the most calories. Public health initiatives aimed at addressing childhood obesity by increasing physical activity would likely be unsuccessful if an active play component was not included. Active play is a much more effective means of burning calories and getting exercise for children than active transportation, such as walking and biking, organized sports, and physical education classes combined. This study concluded that the importance of physical activity on managing childhood obesity has become very apparent. The study also aimed to show the importance of active play as a means to improve the quality of physical activity that the Canadian children, as well as children on the entire North America level, are receiving. And finally, it called for more research to be carried out on utilizing active play as a staple in any public health program for using physical activity to battle obesity in children. After looking at the previous study and all of the risk factors associated with childhood obesity, the pediatric clinics of North America have made some recommendations to tackle this epidemic. These include routine BMI screening for children on an age-appropriate growth chart to identify those who need further assessment, family-centered behavior therapy that focuses on small goals to improve nutritional intake and physical activity while reducing sedentary behavior, and promoting weight loss in small amounts, so 5 to 10% of the overall body weight, because this is associated with improvement in cardiometabolic parameters.
Hi, I'm Dr. Mike Evans, and I want to take a few minutes to reflect on healthy eating, especially with respect to kids, and tell you about a brand new organization at the University of Toronto called the Centre for Child Nutrition, Health and Development. So let's step back for a second. I think it's pretty clear our current nutritional system is broken at both ends of the continuum. The Food and Agriculture Organization's 2013 count revealed that approximately 850 million people are hungry, and at the other end of the continuum, 1.4 billion are overweight or obese. And there are paradoxes within. So, for example, in industrialized countries, the poorest and hungriest are most likely to become obese or develop diabetes and have strokes. Many are simply struggling to put food on the table. 8% of Canadian families and 1 million Canadian kids are food insecure. Many other families are trying their hardest, but are challenged by understanding the best way to eat and then knowing how to make that happen in the real world, all of which drives or prevents the multiple chronic diseases I see all day in my clinic. I also think the public has in many ways been poorly served by nutritional research, where too often the emphasis has been on a very narrow subject, such as one nutrient, with a very narrow population. The findings from this research can help build theories, but for the public it can often lead to confusion and distract us from the big picture of the cascade of behaviors that make up a healthy life. The Ontario government has recently said they want to reduce the prevalence of excess weight and obesity in its children from 30 down to 10% within 10 years. And we think to realize this, our approach needs to change. The Centre for Child Nutrition, Health and Development at the University of Toronto is being built to rethink this cascade and build innovative solutions to help kids and their families eat better. A center that informs individuals and neighborhoods as well as local and global policy. A platform that brings together research institutes like the Li Ka-shing Knowledge Institute at St. Michael's Hospital, the Fraser Mustard Institute for Human Development, and the Hospital for Sick Children, fusing science with care, examining food supply, as well as redesigning medical education across university departments such as nutritional sciences, pediatrics, and family medicine. To bring best practice out of academia into the community where 30% of Canadian kids are overweight or obese, contributing to a population of Canadians whose healthcare costs our system more than $7 billion per year. To take this macro approach, the CCNHD will need to focus on the population that promises the greatest impact, and that window is childhood. For example, we used to see brain development as a fixed process where a genetic blueprint simply unfolds. But now we see a much bigger picture where genes are certainly important, but that your brain actually physically and functionally changes, what we call brain plasticity, with nutrition and experiences, which in turn provides an opportunity for an incredible return on investment down the road. To create a new platform, you need a new team that speaks to this future. So, for example, our microbiome, the trillions of microorganisms that live in our gut, mouth, skin, and elsewhere in our bodies, that help with digestion, prevent disease-causing bacteria, and can nourish our cells. Your microbiome is laid down primarily in early childhood, and the CCNHD has just awarded the Lawson Family Chair in Microbiome Nutrition Research to Dr. Alina Comelli to explore how we can program our biomes to prevent future illness. It's pretty cool. When they asked me to join the CCNHD, I said, but I'm not a superstar nutritional researcher. And they said, true, but instead of being a center that just invests in more research, maybe we also need to invest in curating and explaining the best nutritional research to the world and make it easier for the public to understand and act on that research through YouTube, primary care, social networks, and so on. Food has a ripple effect in our society. Sure, on the one hand towards too much and too unhealthy, but on the other hand, food brings together families, builds communities, and gives us health. The CCNHD wants to build a new platform that explores this balance, especially with respect to our kids, and tips it towards health. So thanks for listening, and we really hope you can get involved with the Center for Child Nutrition, Health, and Development.
So I really enjoyed Dr. Evans' video on childhood obesity. I like that Dr. Evans hit many factors associated with childhood obesity, such as social determinants. So for example, poverty or just being in a low-income family, I find that many health care professionals that promote or try to educate Canadians on childhood obesity do not really focus on this particular subject. So it's really good that Dr. Evans mentioned this and made it aware to families that they're also contribute to childhood obesity and how they can change their ways so that childhood obesity rates can decrease. I know that even though physical activity is very important, I feel that if health professionals looked at childhood obesity at all angles, such as Dr. Evans, I believe that the prevalence in decreasing childhood obesity from 30 to 10% by 2025 could be accomplished. I also like that Dr. Evans went even further and explored future health risks as these children grow up to be adults and the risk of chronic disease such as stroke, type 2 diabetes, cardiovascular disease, and even bowel cancer. I feel that Dr. Evans should have gone into further explanation how Canadians and health professionals can educate Canadians on how to shop, eat smart and affordable for their family in terms of their income and social standing. I would like to add that Dr. Evans should have mentioned how schools could contribute to decrease childhood obesity through additional physical activity in elementary schools, middle schools, and secondary schools. I would also have liked to see Dr. Evans mention community infrastructure in terms of city planning and having recreational centers easily accessible for the community. Um, Overall, I found that the video was very, very, very engaging for its viewers and also viewer friendly. So the language was easily understood by everyone that watches this video.
Next, we will be talking about collaborative efforts on managing childhood obesity. When it comes to obesity, a global epidemic, collaboration between many individuals and levels of care are needed. The impact obesity has on lives is overwhelming and as such requires a heavy role from the government in order to put in place some form of national intervention. There are many levels of collaboration in decision making, with the highest being the national government and the lowest being at the individual level, like healthcare professionals. At the highest level of collaboration, nationwide communication and planning works by finding ways to implement prevention techniques at all levels. In Canada, provincial strategies in preventing obesity are essential since each province may have different levels of children affected. In Ontario, for example, nearly 1 in every 3 children are either overweight or obese. This of course grants an immediate response in which the Ontario government set out to reduce the statistic of overweight children by 20% in 5 years. In order to achieve such a goal, Public Health Ontario collaborated by providing scientific evidence and data to aid in pinpointing how and in which setting children tend to have a risk of becoming obese. The Ontario government also asked for help from the Healthy Kids Panel, which was a great step towards collaboration. With the aid of Healthy Kids Panel in Ontario, a plan to prevent obesity called the No Time to Wait, the Healthy Kids Strategy was developed. This multi-sectoral panel listened to parents, caregivers, youths, and experts in the field, in addition to reviewing literature and strategies in Ontario and other legislatures. With all of this collaboration, a three-part strategy was created. This collaboration involved not only the Government of Ontario, but also the cooperation at the individual level in order to truly grasp all of the information needed to form No Time to Wait strategy. After the national and provincial government established plans, the lower levels, such as the schools and communities, can then aid in implementation. The way schools collaborate is by bringing a perspective from a place that has children sitting and learning for a big portion of their day. The school collaborates with the government in figuring out which foods and eating guidelines are most effective in promoting a healthy child's lifestyle. These guidelines are then taught to children and practiced by the school through cafeterias and the food provided there. In addition, physical activity promotion in and outside of school are key. Having schools allot more time for physical activity during school and promoting physical activity in the community are an example of collaboration. The school promotes healthy active living through education, while the community provides safe areas of play and healthy alternatives of school community. After collaboration between the different groups and levels, the individual aid from the hospital setting is very significant. Since obesity can lead to many comorbidities, the hospital setting requires collaboration from all of the experts and specialists. In order to have successful collaboration, specialists need to have coherent communication with each other. One way to achieve this is to have a leadership group which consists of a specialist from different areas of study, such as general pediatrics, cardiology, and kidney disease divisions. These three divisions collaborated in a study at the Children's Hospital of Chicago. 7 other specialties were recruited into the study by communicating the goal of collaboration to manage childhood obesity in the hospital setting. Once a team is formed, understanding the roles of each division was essential to avoiding confusion and overlap in the teamwork. In addition to defining roles, having the subspecialists identify barriers in identification and management of obesity are very important. Some barriers noted were inadequate personnel, lack of knowledge of referral options, and problems with obtaining educational materials. Another form of collaboration is by having each division recognize where they can best help. For example, specialists from endocrinology and rheumatology report that since obesity and endocrine-related disorders can often go hand in hand, they may be able to provide primary care services on obesity. In addition, pharmacists can also collaborate by identifying the drugs that cause weight gain that are used to treat obesity comorbidities or even just unrelated illnesses a child may have. For example, antipsychotics for children with behavioral disorders can cause rapid weight gain, and this knowledge can prevent specialists from recommending this drug to patients who may be at risk for obesity. Every specialist can play an important role in obesity identification and management due to the comorbidities that are related to the health issue. The example provided from the study done at the Children's Hospital in Chicago outlines how every member of the hospital can work together in one way or another. All in all, collaboration regarding childhood obesity is something that is definitely necessary.
Thank
However,
you for
while the
watching
collaboration may
23 or
start at the
Less,
government
the show
level,
where we
it cannot
talk about
happen
the
without the
topics that
cooperation of
matter.
people at the
Tune in
individual
next
level.
week for our most
The best way for the
controversial
government to
topic
create
yet in our
nationwide
surprise
strategies
guest
is to confer and
appearance.
consult the many parents and caregivers of these obese children who have first-hand experience with the issue.